examination boards for the doctorate of Mr. Upendra PhD, I would like to welcome you to this public defense. You must be aware that this is the very last step in a long process. The candidate has submitted his thesis to the examining board. It was judged, he received written comments, he answered to that. The examining board also had the opportunity to have an internal defense, an internal meeting behind closed doors to already discuss the thesis, the work, and the results with the candidates. At this internal defense, it was decided that the candidate was allowed to publicly defend his thesis today. I would therefore also thank the members of the examination board for the efforts they already did during this process and to today to make this good public defense possible. So thank you. Let me also introduce the examination board. First, professors from outside our university. He is the former dean of the School of Health System Studies of Tata Institute of Social Sciences in Mumbai. So thank you for being here joining us today. The other outside member of the examining board is Professor John Mack, who is the dean of the Faculty of Public Health at the University Catholique Louvain. But unfortunately, Professor Mack will be joining us today. So today he is excused. He was present at and that's their opportunity to discuss the candidates. And we have three professors from our own advantage. We have Professor Brilla Pauw from the Department of Internal Medicine. We have Professor Sarah Williams from the Department of Family Medicine in the UK. And we have Professor Safety Engagement Professor Lucas van Wortel of the Department of Pharmacology. So now I would like to ask the candidates to the presentation will be a general introduction to the work, and the second part will in more detail give us some insight results. Already at this time, I would like to remind you that this is a public defense. So after members of the jury, also from the audience, will have the opportunity to ask a question.
Thank you. Thank you, Chair. Thank you. Hello. Yeah. Thank you, Honorable Chair, to all the jury members, and a very good evening to all of you. I hope I am audible and it's not, it's okay? Yeah. So my PhD topic is enhancing care for chronic conditions and particularly role of local health systems in it. Let me start by I have been working for about 9 years at Institute of Public Health. It's an academic organization based in Bangalore, which is a metropolitan capital city of Karnataka in South India. My institute is engaged in training in public health domain. Now, it was in year 2008 that the national government in India proposed to launch a new health initiative called National Urban Health Mission. Now, the aim of this mission was to make healthcare services available and more accessible to poor urban communities in India. This policy statement by national government brought into debate a whole lot of issues around urban poverty and particularly intra-urban inequities in access to healthcare services in my country. Now, it would take few more years for the initiative to materialize, but some of us at the institute started getting engaged into this debate. And living in Bangalore city, it is very common to see visibly poor areas in otherwise sprawling metropolis. So after having some dialogues with other organizations which were engaged in working with poor urban communities, it was in 2009 that my institute started a long-term project in one of the neighborhoods. Now, the purpose of this project was to find meaningful ways of working with local healthcare providers, with residents in the neighborhood, and with the health authorities to see how can we strengthen the local health services, how can we improve residents' access to quality healthcare. And at the start of the project, we did not have much data. So we did not know how many people live in the neighborhood, what is the health profile of these people. And so very first thing we started off was to do a house-to-house survey, covering all the households in the neighborhood. And the preliminary findings of this survey showed that conditions like diabetes and hypertension were very commonly reported. And this is something which was new because it was thought these conditions only affect wealthy in the country. It is at this stage that my interest in chronic conditions and my interest in health systems converged. And there came an opportunity to do a sandwich PhD program as part of collaboration between my institute in Bangalore and the Institute of Tropical Medicine in Antwerp. So it is with that, let me situate my PhD topic and work in a broader context of my country. I presume many of you would be familiar with India. Located in South Asia, India is the world's largest democracy with a population of above 1.2 billion people. It's a very diverse country in terms of geography and culture. It is also a country of contrast. In present times, India is one of the fastest growing economies in the world. But unfortunately, it is also a home to the world's largest number of poor who are living below the international poverty line. In 2014, nearly 60% of her population lived below $2 a day. In India, we have a mixed health system, so coexisting government and private health system. In government sector, we have an elaborate network of healthcare facilities, starting from community health workers within community. We have primary health centers at village level. We have referral healthcare centers at sub-district level. We have district hospitals providing specialist care. And then there are teaching medical hospitals. But this is more so in rural India. When it comes to urban India and urban cities particularly, the government health services are not so well organized network. And they are generally inadequate. Apart from government sector, we have a huge, relatively unregulated and very heterogeneous private health sector. And most of this sector is in form of small single doctor clinics providing private care, providing outpatient primary care. There are many hospitals of varying sizes, including chain of corporate hospitals, which has been a new phenomena, say in last 1 decade in my country. Now, India represents a very high burden of chronic health conditions. The term chronic condition is often interchangeably used with chronic diseases, sometimes non-communicable diseases. We took a definition by World Health Organization where chronic conditions are referred as health problems that require ongoing management over a period of years or decades. Now in India, chronic conditions became a leading cause of deaths nearly a decade ago. 2014, chronic conditions accounted for 60% of all the deaths in the country. Cardiovascular diseases, chronic respiratory diseases, diabetes and cancers, these are the 4 major chronic conditions. 1 in every 5 adults in India is living with at least 1 chronic condition. And India is a home for world's diabetic. So what does it mean? Because the people with chronic conditions require a long-term, often lifelong care. They often suffer comorbid conditions, and so they have a very complex set of needs across several dimensions: biologic, psychosocial, healthcare services needs. And these are also ever evolving. Now, this is a challenge. This is a challenge because the existing health systems in the country rather evolved in context of responding to acute and infectious conditions. So they are rather geared to provide episodic care, to provide continuous, more holistic care. In recent years, there has been an increase in the amount of scientific literature, though largely based on work in high-income countries, on how health systems could be strengthened or how they can be reoriented to better respond to chronic condition care. There has also been what I would say a heightened political commitment to do so, to reform health systems, particularly among global actors. But there has been very little empirical research, particularly in India, being done at local health system level, which is understood as more operational level of health system at a level of a city or at a level of a village, where policies are to be implemented and health services are to be organized and delivered. And this is crucial for the overall functioning of health systems. About local level, let me also highlight the vulnerabilities faced by poor urban communities in India. In 2011, when the last census was done in the country, we got to know that more than 65 million Indians to over 100 million next year. And people in urban slums lack access to some of the basic amenities in life, such as piped water supply, sanitation facilities, and access to healthcare. Now, because majority of chronic conditions are more common in urban India compared to rural India, I decided to focus my PhD on studying what is the current status of local health system and what role local health system could play in enhancing care for urban poor who are already living with chronic conditions. To do this, we decided to study KG Hali. KG Hali is one of the poor urban neighborhoods and one of the administrative units of Bangalore city, which is a capital city of Karnataka in South India. This is also the neighborhood I referred to in my introduction, where my institute started a kind of a long-term project. Take you all to KG Hali. KG Hali has a population of around 44,500 people who live in an area less than a square kilometer. Population is relatively young. Median age is about 25 years. Population include migrants, internal migrants who come from adjoining states, and so there are at least 4 different languages which are spoken if you cross the streets in the neighborhood. There is a slum in the neighborhood, and most of the people earn their livelihoods by manual or semi-skilled labor or small factory jobs. So the per capita daily income is around €1 a day. Healthcare services, there is a coexisting government and private health services. There are 2 government health centers that provide primary care, and then there are more than 30 private healthcare primary care, and there are 3 hospitals with a varying capacity of 20 to 30 beds. So that's really the context of the study. Now, in order to understand the role that local health system could play, we conducted 3 sequential studies over a period of about 6 years in the same neighborhood. First, we wanted to understand what is the burden of chronic conditions, then analyzing the local health system in detail, and finally trying out a health service intervention to see whether we could improve chronic condition care. So let me first go to the first study. The objectives of the first study were to understand what is the prevalence and profile of chronic conditions in KG Hali, where do people go to seek health care, and how much do they spend on chronic condition care, and how does it affect their life and disease. So we conducted a survey, all the households in KG Hali, and this is the survey again I referred to in the introduction. Because of very high response rate, we were able to generate data for more than 44,500 individuals in the neighborhood. So looking at the results, we found that the prevalence of self-reported chronic conditions among adults was about 14%. Now in India, there are very few studies that looks at prevalence of chronic conditions in urban poor communities. And so far, these estimates are the highest. Hypertension and diabetes were the two most commonly reported chronic conditions. The prevalence of self-reported hypertension was like 10%, and for diabetes it was 6.5%. Now it's important to note that in India, many chronic conditions remain undiagnosed. Prevalence of undiagnosed diabetes is at least as much as that of diagnosed diabetes. And so if we see the true prevalence of diabetes in KG-Hali, would have been at least double the estimate that we got. And so maybe is the case for many other chronic conditions. At least 31% of people in KG-Hali who had reported chronic condition were living with at least 2 or more chronic conditions. So there was quite high multimorbidity in the neighborhood. People who were in older age group and women had much greater odds of reporting chronic conditions. And while KG-Hali itself is a low-income neighborhood, what we found was that poorer the person in terms of per capita income group, greater were the odds of them reporting chronic conditions. In terms of healthcare seeking, it was surprising that most of the urban poor in KG-Hali relied on private health sector. Very significant positive association between per capita income and the preference for private healthcare. However, those who are poorest of poor, people living in below the poverty line households, those who are elderly, and those who require hospital care, prefer government sector. These findings were published as a paper in BMC Health Service Research. Let's look at healthcare expenditures. So 1 in 3 families had to spend out of pocket on chronic condition care. And as a result, 16% of households, that's 1 in 6 families in the neighborhood, had to spend more than 10% of their monthly household income on outpatient care of chronic conditions. So that's a financial catastrophe for them. Now it's important because generally hospitalizations are seen as catastrophic events. But our study corroborates with just a couple of other studies available in country which looks at healthcare expenditures on chronic conditions, and they show that people with chronic conditions, because they require a frequent outpatient care, that the payments made on outpatient care are also catastrophic. Drugs were the major driver of the cost, accounting for nearly 70% of the out-of-pocket payments which were made on chronic condition care. The poorer the person was, the greater were the odds that they will experience financial catastrophe. And also poorer families spent higher share of their income on outpatient care. This means that what is left over is generally very meager money. And as a result, there was expansion but also deepening of poverty for people living with chronic conditions in the neighborhood. The number of people who were living with chronic conditions below poverty line in the neighborhood got doubled in 1 month duration, merely because they had to spend out of pocket on chronic condition care. So based on this data, we wrote a paper in BMC Public Health with my KG-Hali project team members and supervisors as the co-researchers. So if I summarize my learnings from the first study, where that there is high burden of chronic conditions in KG-Hali, that majority of poor depend on private healthcare sector, that drugs are the major cost driver, and that those who are able to seek healthcare is impoverishing, and particularly so for the poorer section of the community. With that, let me move to the second study. At this moment, at this stage of the study, to simplify it a bit, we took diabetes mellitus type 2 as a proxy for chronic conditions, and we conducted qualitative studies in 2 stages. First, we wanted to understand from diabetic patients as to what are the constraints they face in a day-to-day managing diabetes care. We conducted in-depth interviews with 16 diabetic patients using phenomenology, sociology, and anthropology to understand the patient's lived experiences and the kind of lay meanings they put in health and illness. And so we selected the patients with help from community health workers in KG Hali, ensuring that we have a mix of both the sexes and that the patients represent different stages of diabetes and treatment. Stage, we wanted to learn from local healthcare providers on how diabetes care is organized in the neighborhood. And to do this, we sampled all the healthcare facilities in the area that provided diabetes care. And then we interviewed the doctors at these facilities, because in our context, the doctors are the owners and the managers of the facility. We also interviewed a few pharmacists and laboratory technicians who mainly work into the private and private laboratory and pharmacies, which are isolated. Unlike in case of patients, interviews with healthcare providers were a bit more structured using the health system dynamics framework. This framework is a bit broader analytical framework for health systems. It already includes all the health system building blocks as proposed by the World Health Organization. But it goes a little beyond. What it does is it makes the interconnectedness of these components more explicit, but it also emphasizes a few elements which are generally missing in those building blocks, such as context and the importance of values and principles that guide health systems. Let us go into results, and I'll first go into, let's look at the themes that defined the major constraints which were faced by the diabetic patients. The financial hardship really shapes the way people live and seek healthcare. So a day-to-day struggle of earning a livelihood and bringing food in family put diabetes care on a lesser priority. At the time of the study, families of half of the respondents were already into financial debt. One of the patients said that if I have to spend 10 rupees to buy tablets, which is like 20 cents, I would think twice. I would rather buy a coconut and make a chutney for the family dinner. Another fed up of paying interest on financial loans. We don't know when we'll come out of this, and we will peacefully drink ganji, which is like a rice porridge. So apparently the financial distress was compromising the care. Many patients had to discontinue the treatment, and some patients had to take lesser dosages than the prescribed dosages of the tablets. A very strongly defined gender-based role disadvantaged women for diabetes care. In that context, women are generally expected to cook food, to take care of the household chores, to raise children, and this constrains them, their mobility in going out, taking a walk, going out and seek care from distant health facility. The intra-household power dynamics means that women remain subservient to the rest of the family. So women were the last one to eat in the family, eating whatever is left over rather than exercising a choice of what suits their diabetic condition. The situation for elderly were not very different. In KG Hali, but also in general in urban India, the family structure is changing. So with increasingly nuclear family structure, more and more elderly now live alone, but they are financially dependent on their married son. And this restricts the kind of support they would have otherwise received in, say, generational conflicts. And this puts elderly into a bit of a lesser social position in Indian families. One grandfather who was interviewed, he said that my son is able to buy medications, but he probably feels that it's a waste of money because I'm old. Many patients were not happy with the negative attitude and inadequate communications by their healthcare providers. The doctors hardly explained their prescription, leave apart engaging in a dialogue with their patients. One of the patients said that we have so many problems at home. When we go to healthcare facility, we are worrying about those problems. And we really expect that in that situation, our doctors listen to us and talk to us properly. Finally, patients are also concerned with very fragmented nature of healthcare services in the neighborhood. So patient had to visit many healthcare facilities for a single episode of care. One of the patients put it very clearly, said that I go to a government health center and they ask me to go to a private laboratory to get blood sugar done, back to the government center, and they write so many medications that half of which are not available there. And so I have to go to private pharmacy. So if you really want to help poor, have things available at one place. So based on these findings, we published a paper in Global Health Action. Now, The use of health system dynamics framework helped us identify some of the systemic impediments in the local health system. And these were mainly along 4 elements of the local health system. There was plurality in healthcare delivery, plurality in both the sense of having a varied kind of healthcare delivery platforms in the neighborhood, but also different systems in which doctors were trained, particularly Ayurveda and Unani, apart from the modern medicine. As you might be aware that in India, there are many other traditional systems of medicine like Ayurveda, Yoga, Unani, homeopathy, that these all have become legalized and they are made part of the dominant healthcare system. Now, having plurality itself is not a problem, but I think the problem came when there was no coordination across different healthcare providers and care delivery platforms. And this led to overlaps and gaps. I give you an example that the hospitals which were providing referral care in the neighborhood also provided a basic primary care with a significant overlap with small clinics and health centers in the area, but also leading to crowding at the doctors. Systems other than modern medicine often ended up practicing modern medicine. And this apparently compromised their competence of practicing modern medicine. There was inadequate use of information to better manage chronic conditions. 6 out of 15 healthcare facilities that provided diabetes care in KG Halli were using some form of patient medical records. The other facility did not use any kind of records. Even in these 6 facilities, what they used was manual paper-based patient health records, but there were no corresponding records at facility level. So if the patient doesn't go back to the healthcare facility, there is no way to track that patient, or there is no way to send reminders to the patient. So this impacted the continuity of care. The pharmaceutical industry had a very huge influence on local doctors' knowledge. So the pharmaceutical representatives made periodic visits to individual healthcare providers, and pharma companies often sponsored the continual medical education programs of the doctors in the neighborhood. There was a lack of effective leadership and governance. We interpreted leadership and governance in a bit of a narrow sense as compliance to the prevailing laws and policies related to healthcare, but also coordination across varied actors in the health system, and both were largely missing. There was widespread bribery, corruption in form of kickbacks between doctors and pharmacies, doctors and laboratories. There were few private doctors who shared that how easy it was to bribe lower level regulatory officers to get license without having to meet prescribed conditions to practice medicine in the area. And finally, the narratives of healthcare providers point of provision in neighborhood. And the dominant notion was the maximization of profit. Many doctors said how there has been a shift from more service-oriented profession to more just like another business. There were few doctors who were concerned about poverty in the neighborhood, and they generally subsidized their consultation fees, and they participated in community outreach services. They looked these as the small acts of charity for the poor. There are also issues around the trust deficits, particularly between specialist doctors and non-specialist doctors. So the primary care providers in KG Halli often hesitate to refer a patient to specialists because they feel that they will not refer the patient back and they will lose their patients. We published these findings as a paper in PLOS 1. So if I summarize my learnings from the second study, that despite having several abundant of healthcare facilities in the neighborhood, the diabetic patients still face many barriers in managing diabetes care, and that there are systemic impediments in organization of local health system, because of which it is difficult to deliver more continuous, integrated, and more person-centered diabetes care. With that, I now move to the third and the last part of the doctoral research. In this part, we worked very closely with the local healthcare providers. We had at least 6 dialogues over a period of 2 months to understand what are the things that they felt they can actually do within their routine practice. And so based on that, we set up a quasi-experimental study on how health service intervention would enhance diabetes care in the neighborhood. So we started working with 4 healthcare facilities in the area were an intervention. Intervention consisted of 3 elements. Provision of culturally appropriate diabetes education using posters and videos in the patient waiting areas at the facility. And the doctors were expected to prescribe generic medications to reduce the cost and to use standard treatment guidelines. Now, as you would notice that this intervention does not closely respond to what we find in earlier parts of the study, where not just medical care, but there are many social issues, right, that impact diabetes care. And this was a limitation because in that given space and time, we had working relationships mainly with doctors, the healthcare providers in the area. And they were very preoccupied with biomedical care provision. And it was important to have them on the board to be able to do a study in that neighborhood. So with that limitations, we then selected another 4 matching healthcare facilities as control. The last healthcare seeking visits, we recruited diabetic patients into both the groups. We used a REAIM framework for data analysis, a framework that goes beyond just assessing efficacy, which is often done in randomized controlled trials, but also look at other important public health dimensions of health service intervention. So with that, let me go into results by different REAIM dimensions. Over half of the patients who actually went to intervention sites saw both the videos and the posters. And very few, just 8 patients were actually prescribed generic medications. So this limited reach of interventions also compromised the needed sample size to calculate the efficacy. The doctors at the intervention sites, they felt that educational component was very useful. They felt that after watching videos and posters, their patients were asking them more questions about their condition. But the use of difference in difference analysis did not show any statistically significant improvement in patient outcomes, be it their knowledge or the self-management practices. So in terms of adoption, all the 4 facilities adopted the educational part of it. They all displayed posters in prominent site, run the television and the videos. But apparently there was poor adoption of prescribing generic medications and the use of standard treatment guidelines. The qualitative data collected in the study helped explain some of these barriers. So the doctors had a very strong perception that generic medications are of less efficacy and they are of poor quality. Also felt that their patients will not accept these medications. And their argument was that the generic medications are single compound medications. And in the neighborhood, it is very common for doctors to write combination drugs. And because diabetic patients generally have comorbidities, they said if we use generic medications, our patients have to end up taking more number of tablets, and that they felt that will not be acceptable to them. Finally, some doctors were concerned about limited availability of generic medications. So they said that we are dealing with migratory population, so we want to write kind of brand medications which are more universally available beyond KG-Hali. So my patient shifts somewhere else, and then it's not a problem. In terms of use of standard treatment guidelines, doctors had this strong perception that their patients expected them to really prescribe things, and this limited scope of using a kind of a non-medical avenues of behavioral change communications and things. Also, many diabetic patients were diagnosed by specialists out of KG-Hali, and so the primary care doctors in KG-Hali had little say in changing their treatment plan. All the 4 intervention sites continued delivering the educational component beyond the study period. And we published these findings as a paper in a Global Health Action. So if I summarize, implemented, and it actually didn't lead to any significant clinical improvement. That the strong perceptions of doctors, both about generic medications, but also what their patients expect from them, were barriers, and that implementing such interventions or any positive change in local health system need to consider the complexity, the dynamics within the system. So with that, I come to the last slide where I would try to summarize broad insights over the period of doctoral research. One is very clear that the chronic conditions are no longer affecting only wealthy. And that's why the whole discourse around prevention and control of chronic conditions, which is largely focused on prevention, because in literature we read a lot about lifestyle change and things. I think prevention is important, but in context like India, where a huge number of people already live with chronic conditions, it is important to also emphasize on need to provide affordable quality care for people living with chronic conditions, particularly so for urban poor. KG Hali experience, I understand, cannot be readily generalized at a national and macro level, but there are issues within KG Hali that points to policy gaps. And I will take an example, say financial protection for health. In India, national and state governments in last 10 years have come out with many health insurance programs which are targeted at poor. And the idea is to protect them from the catastrophic impact of healthcare payments. Now, none of these health insurance programs cover outpatient care. They only cover hospitalizations. Now we see that outpatient care remains a major source of iatrogenic poverty among people living with chronic conditions. Another example could be that, like we see in KG Hali, most of the urban poor rely on private sector. And that means that we can't really do much without really engaging with private sector. But most of the government initiative, whether they are about chronic conditions or whether they are about improving services for urban poor, they really ignore private sector. They are framed as if only keeping the government system in mind. So there is need for the government to go beyond just being a funder and provider of healthcare, but also play an active role in governance of these mixed health systems, where you have health systems are complex, and we cannot just take more efficacious intervention hoping it to get readily implemented and give positive outcomes in that linear logic. Having said that, there are opportunities at local level, and I give example from KG Hali, that a government health center in KG Hali often reached out to private health facilities, wanting them to report cases of tuberculosis and wanting them to use a standard treatment regime for tuberculosis. Similarly, there were some private providers who were relying on government health centers for free supply of materials like condoms and vaccines. So there are such opportunities exist. If carefully nurtured, we can probably work out better coordination across sectors which are generally working in silos. Also, like I mentioned earlier, there were few private medical providers who were using manual patient records, and I think that is something that could be a way forward to improve continuity of care. And finally, while there is room to improve local health systems, and I think it is important to do, the health systems alone are not the answer when it comes to prevention and control of chronic conditions. Issues we see in KG Hali like general poverty, age and gender-based social positionalities, changing family structures, very inadequate welfare provision within the state. These are really beyond the remit of health systems, at least the way traditionally we define health systems today. And so it's important to address these broader social determinants of chronic conditions using more multi-sectoral health in all policy kind of an approach. But also more importantly, at a more operational local health system level, it is needed that we complement the provision of healthcare with provision of social care. With that, I thank you, all of you, for your attention.
Candidates, thank you for taking us to India and to take us on a tour of your work and to give us some insights on the details and what you work. Thank you also for sticking to the time that you received. I will make sure that also the executive board sticks to the time. Now it's time for the questions and for your answers. Let me first give the word to Professor Julian as the first.
Upendra PhD, you have done a study which is not very well researched in the country in terms of urban health of the poor, which is less researched, and also the chronic condition, and above all, analyzing the local health systems, which is very, very important area where very little research is done in the country. So, congratulate you for taking up such a bold initiative to take this research.
Thank you.
I just want to raise one or two questions. I have raised some questions in my written review, but I would like to go beyond that, much broader at this juncture. The first one is the first sub-studies where you have the out-of-pocket expenditure and also the catastrophic health expenditure. And you have very well brought out how outpatient care leading to catastrophic health expenditure, where the drug forms is 69% of the cost. That's the main driver. And then in your last chapter on pay forward and policy options you have discussed, which didn't come out in this presentation, but which I have read, there you are more focusing on ameliorate this financial burden of catastrophic health expenditure and how to help people financially. Don't you think as a public health professional, your study focus should be either dealing with the economic burden or it is the disease burden? So this is generally in India, the research direction of late, moving more towards financial burden of disease. And there is a dichotomy between financial burden and disease burden. And the policymakers are simplistic in understanding financial burden. So if it is 69% is medical cost, medicine cost, it's very easy for the government to provide them that much money. So that's exactly happening in the new initiatives. So can you bring your study on financial burden that deal with the disease burden? So that is the primary goal of our public health goal. So that is one question. So the linkage between the economic burden to the disease burden. So that I feel there is some gap in that. The second one, the very last point you have brought out, very rightly you said the issues in KD Delhi that matter any urban slum is beyond health systems. Actually, health systems is defined not simply as healthcare institutions. It is the healthcare institutions and any resources, any individuals, any functions that contribute to the health of the individual. So in that sense, your second study and the third sub-studies were brought out excellent findings of people health being affected or seeking healthcare being affected because of factors like gender, age, or lack of communication between the practitioner and the patient. All these have been brought out. But why don't you introduce this in your intervention side? And you just concluded that it's important to look into it, but you know very well if you want to treat diabetes, it is not the doctor's behavior, not the patient's behavior, but there is a local health system. That's why the analysis of local health system you have brought out very well. But you have not at the end round it off with saying how you put your health system in the KD Delhi is beyond these medical practitioners and other things. So these are two questions. I will stop with that, and later maybe if there is time.
Thank you. Chair, shall I answer? Yeah. So, yes, I think I fully agree with the way you brought out kind of a dichotomy in focusing on disease burden and on economic burden, and we see more and more studies around that, because I think, like you said, maybe to policymakers it is easy to understand, and they are also more concerned about the economy. And when we talk about financial burden, it becomes a little easier to buy the political will on that side. But and that's what is happening in country, because like you mentioned, the generic medications is gaining a very huge political support at different levels, both at national and state level. Some state governments have come out with the generic medications schemes, but while there are no formal evaluations to my knowledge, but it seems that similarly how we felt in KG these generic medications are not being able to make much impact in terms of patients' lives, and so even on financial part it is not helping enough. In terms of prevention and disease burden part, I feel it's important that while we might start with economic argument just to buy a policy attention, but to go more on prevention part. So maybe just because I was working with people who are already living with chronic conditions, maybe I focus much more on the care and care for them. But there is a huge room around prevention of these chronic conditions, and that's why probably reducing disease burden over time. And I could think of things like using outreach health workers who are currently, their services are much limited to maternal and child health care or just minor ailments, could be a good source of exploring whether there could be agents who can support self-management, say at a community level. Because we don't have formal social care workers like probably in this part of country. Similarly, maybe I feel health, the task shifting part is another thing which is gaining a momentum, and we see more and more experiments where, because our systems are doctor-centric, that doctors are not able to give time, but whether some tasks can be delegated to more lower-level workers, say nurses and pharmacists, and there have been few such experiments in India, to see whether they can be they can provide more preventive educations. So I guess there could be possibility to link the financial burden argument, which is more easy to get policy attention, and then push for things which probably help in reducing the burden. And I think the more important thing is also the other sectors that play a role in prevention than the healthcare sector alone. I don't know whether I answered to your satisfaction for the first question. I go to the second part of it. If you can help me, you said about
the social factors.
Yes.
Which you have brought very well.
Yes, how the whole system, rather than just the medical institutions.
Bringing to your health system these components.
Right, true. So, and I agree that that's why I also felt that our intervention was too much medical in a sense, and in that moment we did not have working relationships with other actors. But like you rightly said, I mean the idea of whole view of health system is any resource which is available that can be used for health. And so while the study ended now before 1.5 years, because there was a delay in coming to state, precisely the attempts are in that direction on how to use other resources to better the chronic condition care. So one was to facilitate. So one is the community health workers, who are generally women from the same neighborhood. So they are now going house to house, making periodic visits, and they are doing mainly two things. One is they provide education around chronic conditions and how to prevent those, and those who are having it, how to better self-manage those. And second, they link these people to affordable resources in the area. So for example, there are some hospitals where the doctors are more socially oriented, and they provide subsidized care for the poor. There are certain elderly homes, for example. So there is while there is very little state support for elderly, but these are the resources which are available in the area, which are often not, the patients don't really are aware of it, and these community health workers link them to these different resources. Other thing that the project has taken up is about access to ration card. Now the ration card, which is income proof, but also more importantly proof of below poverty line status of a household, becomes kind of a major document to get into many welfare schemes, be it elderly pension or be it even health insurance schemes like RSPY. And in KG Hali, as we noticed that nearly 1/3 of the households population in the area did not possess ration card. So that's another thing where our project team worked with the local elected leader who is a member of Legislative Assembly and facilitated kind of mobilization within the community where different department service providers come, set up a kind of outreach service camp, and our community health workers mobilize people to go and get these documents so that basically easing out their access to available insurance but also social care schemes. At third level, what we are trying to do is, and we are in a process of that, is to try to work with other departments other than health and trying to see whether we can come out with possible opportunities to work. I give you example in AIDS control program in Karnataka. There was this MOU between memorandum of understanding between the health department and the rural development department, because that MOU made it so easy that the moment HIV person was identified, he was given access to all the social programs, irrespective whether he had ration card or not. So maybe there are opportunities which we now want to explore through such work with other departments.
Would you like to reply or pose another question?
Yeah, your second part, I suppose when you finished your thesis, it was only 6 months. So I'm happy to hear.
Yeah.
But I'm still not very convinced with your answer of the first question.
Okay.
Because the disease burden being the focus. Like for example, now most of the state governments have or RSPY, or they have either insurance programs or reimbursement for any catastrophic type of health expenditure likely to be incurred, mainly hospitalization. So governments are reimbursing them, and say the Maharashtra government even pays about 150,000 rupees, which is a big amount for major surgeries and other things. So they are not going to ultimately reduce the disease burden. Similarly, complications of diabetes is taken care of by the government. Any hospitalization related to retinopathy or renopathy, anything is paid by the government for treatment. But the disease management, prevention, these have been neglected. So the linkage with the meeting the financial burden to backside, linking it to the disease management, and so if you are going to do the same thing, the 69 million diabetic patients today in India, in 10 years they are going to be 109 million. That's what they predict. So I'm talking about the linking it to the backside, disease management, prevention, promotion. So that part of it didn't come out very well in the thesis.
Yeah, I think I agree with that observation. In fact, I see that even at country level, it's now that we are talking about estimating what will be the benefit of preventing chronic conditions and making that argument in order to sort of which I came across during my 6 years of work, because there is a national program on prevention of cardiovascular diseases, diabetes and stroke. But what I realized that the program was more operational only at district level, and then there were outreach screening camps. So they were, and naturally when they did screening, they identify more number of patients who don't know that they have diabetes. But then there was no services available at primary health center level. So it was creating a bit of this tension in the community. But I agree that I did not cover that aspect at all of reducing the burden.
So now I would like to invite questions.
Thank you. I would also start with congratulating you.
Thank you.
It is a lot of work. It's nice work. Wrote a nice thesis and give nice presentation. It was clear and sound. We already discussed some methodological questions, so I would continue rather challenge your ideas on general healthcare, especially with respect to diabetes. So Professor Yuzukian already mentioned that the burden of disease is much more than only treatment. This care is really based on 4 pillars: screening, prevention, treatment of diabetes, screening and treatment of complications. I will go further on the previous discussion. What do you think is most urgent of those 4 pillars? What in KG Halley, what would you address first if you had the means? And that the means are of course limited.
Well, it's a difficult question. While I was working in KG Halley, I realized, like I said earlier, that maybe we are in a point of time where we are struggling. Actually, our health systems. This is really a litmus test to our health systems. We are not able to respond to. Tend to believe that you are going for massive screenings at this stage, to me, can be counterproductive. It may lead to trust issues within the community and the health services, because we end up, as I said, I mean, diabetes, but also hypertension. We have nearly double the prevalence of undiagnosed and diagnosed conditions are nearly same. So I'm not against screening. I think I very much support, like you said, it's a basic component of managing these conditions. But given the limited resources and the stage we are in, I feel that more widespread screenings will only identify more patients who then our health services are already struggling to cater to. So I think this is also the time where some fundamental reforms need to be made in health systems, and maybe that can be focused much more. Things like investment. In India, the public expenditure on health systems, on healthcare in general, is just 1% of GDP. And so this is while the private expenditure by individuals out of pocket is like 2.5% of GDP. So I think probably, I mean, if one has to select the priorities where to focus, maybe I would go in more in strengthening the existing and reorienting health services, which then can also do other things better. Because currently what is happening is that in vertical logics, for each disease and conditions, there have been programs which are formulated. So you will have a separate program for diabetes, a separate program for mental health and things like that. But these programs, however, looks good, they face problems because the systems that need to deliver those programs are very weak anyway. So I would try to, I mean, if I need to bring advocacy attention, I would rather bring it to the fact that we need to strengthen our healthcare systems, and then there are clear reforms which need to be done and which have been long pending in the country.
So first, elaborating on treatment before going to testing. It was remarkable to read in your thesis that among those healthcare providers, there are some who are treating patients but never received formal medical training, or at least they did not qualify any exams. So I was wondering, how common is this in KG Halley or the bigger city, the area, or even in the whole of India? Whether this is tolerated by governments or not, and if you feel that this is a problem which should be addressed.
Yeah, it's a very interesting question. And before I answer that, I would like to go to your first question, just to correct myself, because I feel what I'm trying to do is not really also focus on treatment. What I'm trying, during my work also, I try to not focus on disease per se. Of course, I had to take diabetes as a proxy. My argument was more in favor of the changing the system, because some of the care demands are quite common. So for example, worrying about information system, that we don't have medical records, that we don't have referral systems and those things. But coming to a second question, it is very common to have such providers who do not have basic degree of practicing a particular system of medicine. In a recent policy brief by the government of India, they put it estimate at around 50%, that the 50% of India's health workforce are informal care providers, meaning providers who do not have the needed education level. In KG Hali, we only had 3 out of about 32 care providers who had needed a degree. So yes, it's a very widespread. Whether government tolerates it, not in theory, but in practice, yes, because this is not a new issue. It is known for many years in the country, and legally, I mean, if you take a legal stand, then people who do not have these degrees are not allowed to practice legally. So on paper, they are all illegal providers. But we have never seen sort of government going out and enforcing the existing laws. And so that's why I think there is a lot of, I would say, I think, yeah, in narrow terms, government do tolerate them. Sometimes also maybe realizing that their services are inadequate, and often in such poor areas, it is these informal providers who are the first point of care for many patients. They also enjoy kind of a social support because of the various characteristics that they have.
So to integrate them and to train them, give them a formal medical training, would that be an option?
It is certainly an option, and I think it's a long-term ongoing debate in the country where there are diverging point of views. There are people who are very much in support of getting these people and formalize them into a system. But we have a very strong unions, professional associations of modern medical practitioners who are very powerful, and they are very much against this for natural reasons. Over the time, various governments have tried. I think there have been formal attempts like creating a new degree in healthcare, where you do not require that much time investment, and some of these people can be readily trained into that. But in practice, this has not been done. These people still have not been formalized into the system.
Maybe short final question. So you're focused on type 2 diabetes mellitus, which is more, I would say, lifestyle-related disease. Another chronic endocrine disease is type 1 diabetes. There must be some patients with type 1 diabetes on a population of 45,000. Is there a healthcare system taking care of type 1 diabetes in India? Do they get other types of care?
So yeah, there were children's, but I mean, there is no separate kind of a system to only deal with that, and because they often require routine insulin on an ongoing basis, they invariably have to end up at hospitals setup, and they have if they can't afford, then they have to end up in government hospital, and that's what generally happens. And that's why also at the hospital level there is more preference for government rather than private. Specific features of the system that caters to such a group, I to my knowledge, no such programs or features exist.
Okay.
Thank you.
So next, I will give the floor to Professor Simon to ask questions.
I think we always did a great job of presenting it very clear and transparent, and I think he did this also today. I think it's a very important competence researchers should have. I think we need to be able to communicate our findings to the public. I think he did this very well. So congratulations.
Thank you.
We already exchanged also some thoughts
Yes.
within our internal defense, and it was very interesting to talk to you. And I had two other things that I thought I would like to hear you about. At a certain point, you wrote in when we had a discussion one paper you gave me as an answer, there seemed to be room for gatekeeping at primary care level, with a potential to reduce the out-of-pocket payments by patients in outpatient care. Could you comment on this? Do you see evidence in other countries of this gatekeeping system? And if you would like to take this further, how would you do that?
Yeah, the rationale for we sort of making that point in the paper was that in our healthcare expenditure study, that the incidence of out-of-pocket payment was significantly higher at referral level compared to primary care level. And we also found that the median amount of out-of-pocket payment was also higher at a referral level compared to primary care level. But then when we looked at the healthcare seeking, over 50% of chronic conditions people were seeking care from hospitals on an outpatient basis. And there lies our assumption that maybe not all of them actually go there for the hospital care. They are actually getting the routine primary care, which could have been provided at a lower level. And that point comes. Now, it is very complex. I can see that in current system, there is a government system where it is somewhat possible. Because in government system, at least there is a well delineated levels of care. So we have well delineated different three-tier system. And only thing is we are currently not doing very active gatekeeping in that system. So the person can easily go to a referral care without having to go through a primary care. In private, it is very, very difficult because they are not regulated at all. So they all work like individual entrepreneurs, and there is no system through which medical records can be easily shared. So hospitals have started for their own benefits, I think, to get into very efficient data systems. But again, those are only specific hospitals. So I think there are huge challenges in terms of sorting out this issue of not just gatekeeping, which is, I think, where I come from, but also the continuity of care in terms of medical information across providers and stuff.
If you look at the gatekeeping, there are many other countries using a gatekeeping system. Does it show that it works? Would it lower indeed the
when I was doing literature review during that study, I did find sort of papers that rather talked about importance of gatekeeping in terms of reducing expenditure, but also there were other benefits of gatekeeping, of course, and one of the peril was the crowding at government, the tertiary crowding can be reduced because a lot of people who end up there are actually seeking basic healthcare and not really the tertiary care. So
something completely different. You mentioned that in the interviews that you did with patients, is that patients complain or have problems with the way the healthcare provider talks to them, the communication, the fact that that their context is not always taken into account. If doctors prescribe medications, a list of 10 medications, if they would talk to the patient, they would know that this would be impossible for the patient to buy. So there is something wrong there. There is a communication problem between the doctor, the provider, and the patient. How could this be tackled?
Yes, I think, well, let me go to KGHL experience and see how one could approach such issues. I think the answers lies at two levels. One is more institutional or rather fundamental level, where issues like no control, issues like, for example, fee-for-service system, which all the private sector in India works, has an incentive that the doctor sees more and more patients, and that's the only way he can build more money, rather than spending more time on one patient. So that is something that constrains doctors in doing that. Also, we don't have regulations of private healthcare. Well, now many states have brought in such regulations where you have to register a private health community. Currently, most of the private clinics are like single doctor clinics. So a doctor comes, opens the thing and practice. There is no other staff apart generally from one clinic staff or one attender who generally manages the patient's queues. There are no other supporting health workers to which doctor can delegate things easily. So these are more, of course, more broader macro issues where change can actually make the environment more favorable for doctors to go into that logic. At local level, what I felt was that many doctors were coming from very affluent areas, practicing in Kejihali for part of the time. So they would also have in other area of the city another medical facility. So I felt in my interactions over these years that I doubt whether they really knew that there are pockets of people within the same Kejihali where people don't have anything to eat and things like that, you know. So I think the surrounding of doctor, where they all the time see pharma representatives luring them with different offers and things, somehow the whole awareness of the kind of clients base that they are serving to is not there. And
how did you prepare in your education?
yes, I think medical education is an area where there needs to be an intervention. Some governments, for example, also gave subsidies to private hospitals on a condition that they would serve poor. But then these never really worked in practice. So I think a more socialization or more part of the medical education that talks about broader social determinants, that talk about person-centeredness, what is the real value of putting patient in the center of the care, and more importantly, the fundamental reforms in medical education system, because now what we are doing really is we are only there is this inequality a doctor. If you come from a very poor family, it is very less likely that you will end up being a doctor, because all the training institutes are generally located in metropolitan city, mushrooming of private education system where you have to pay a lot of fees. The doctor told me that I have no other way than to work like this because I paid so much in the private education. This is now my time to recover money. So I think that kind of ecology doesn't make it easy. But certainly medical education needs to do much more than currently. We don't have much of this. We don't teach humanities. We don't teach other things as part of medical education. Thank you.
And finally, Professor Humberto will also be able to raise his questions.
Thank you, and congratulations for this nice piece of work on
Thank
a
you.
very extremely important topic, which is not only a topic which is important for India, but also for other countries in our world. So I would like to ask you some questions, and you will not be surprised that as a clinical pharmacologist that the focus will be mainly on pharmacotherapy and the treatment and less on prevention. Is it right? You mentioned that the doctors and also patients, or the doctors believe that the patients do not trust the generic drugs. The drugs are made in India. And are they right or are they wrong? Because we did a study a few years ago, taking from Rwanda some drugs, and we found substandard quality of captopril from a manufacturer from India. The question is, how is the quality of the drugs controlled? Because I know that is a major topic in WHO. The group of Lamitrago is completely spent on the quality of the drugs globally. How is it controlled, the drugs in your country, and if good enough, I don't know, but what if you are Minister of Health, and you will become that in a few months or in a few years, then
it's a very important concern that you bring. Answer, we do not have good quality control on manufacturing of generic medicines. And some of these doctors who talk about poor quality of generic medicines, I'm sure they were not all talking from financial angle of them getting more money from brand, but they were actually having real concerns, because when they switched from generics to brand medications, in their experience, they used to get quicker results and better results. And in last year, the Parliamentary Standing Committee on Ministry of Health and Family Welfare came out with a separate report on drug safety, and that was revealing, because this is the government's own committee, which was saying that we are not doing enough at all in terms of quality. Many expert groups which were set up to approve the drugs included representatives of the pharmaceutical companies in the country of need to step up the quality, because there are so many generic manufacturing units, which is like a cottage industry, where there is no oversight on. So there are few big companies which produce brand medications and also have generic parts, but then there are so many small household kind of factories which produce generic medications, where there is no oversight really on whether they are effective or not. And I also recently read some literature in the international arena that even those who are supporting generic medications, they are worrying that such perception of Indian generics are not problematic for India, but also many other worlds where India is a major supplier of generic medications. So I think that's a real concern in the country.
Thank you. Then I would like to move on to the fact that a drug has to be taken by the patient. If it is prescribed but not taken by the patient, it is useless. Also in our country, that's a problem. Sometimes you find in houses with elderly people a full locker, with pharmacy locker full of things kept as a treasure, and so they are not taken. So that's a problem. But in your country, there is like in other lower middle income countries, there is a supplementary problem, the affordability. And so the question is, the WHO essential drug list, can that, which is produced also in part to get more affordable drugs on the market. Can that help? I noticed that you have used glibenclamide and atenolol as examples. I have noticed that they are not the first line drugs in the bisoprolol, which are first line drugs, they are second line. One question is it of help that the WHO list of essential drugs? And the second one is you have guidelines. The guidelines are normally for optimal treatment, but optimal treatment is not always affordable, especially for the poor. So should there be other guidelines than for the very poor than for the more relative in your country? How should you do it?
Yes, in your first question, I agree. I mentioned those drugs because I think I came across studies which actually evaluated the availability of those drugs in our public facilities. But, well, I would say it would be helpful to have these drugs on WHO list. The current government in India has at least shown sort of commitment to make many medications available freely at public facilities. But this scheme has not yet taken off. It has been announced, and some 50 medications. They include some of the first-line commonly used medications for some common chronic conditions, including diabetes. But I guess while we do not have much of aid-based financing, we don't have much of outside. But WHO does exercise quite kind of control in terms of technical advocacy. So it would be helpful, particularly in current times, where our prime to not look very nationalistic, but really seek inputs from various quarters. I think that can be an useful move. I'm not sure whether it would actually translate because that requires a lot more other advocacy from national and state level to get something done on that. And I don't know why I'm forgetting always. The second thing you asked me about.
It was the guidelines.
Oh, the guidelines. Yes. Whether we should have two different guidelines. Yeah. I think, I mean, one of the constraints, like you highlighted, and I also saw it a lot more reported in literature, was that it is because of the cost of the treatment that often guidelines are not used. Because when you, as a doctor, you know that my patients are not going to be able to buy all that, I deviate from the guideline. Whether to have two separate guidelines, one for, say, relatively poor, I think it has never become a big debate in the country. But whenever something like this has come up, a lot of ethical issues has come up, saying that in India, do you treat poor differently than the rest of the population?